Hi, my name is Osama and I will continue the pediatric board review series explaining in this video the gastroenterology chapter in the pediatric board study guide. The main references I used to prepare this video: the pediatric board study guide, Nelson, Pediatrics in Review, AAP Prep Curriculums. In this video I divided the gastroenterology chapter to three parts. Part 1, nutrition and acute abdomen, and this is what we'll discuss in this video. Next will be part 2, upper GI disorder, lower GI disorder. Part 3, lower GI disorder will continue, and liver diseases. We'll start now the gastroenterology chapter part 1 from page 257 to page 64. The first part will discuss nutrition, calories. 1 gram of carbohydrate gives 4 calories. 1 gram of protein gives 4 calories. 1 gram of fat gives 9 calories. So remember, carbohydrate and protein are the same. Each 1 gram will give 4 calories. The fat is more than double, will give you 9 calories. Infant formulas, each 30 milliliter or 1 ounce will give you 20 calories. Each 1 ounce or 30 milliliter will give you 20 calories of infant formula. Full-term and preterm infants, they require 100 to 140 calories per kilo per day in order for them to grow. In malnourished children, they require more energy. They require from 20 to 30% more energy in order for them to catch up in their growth. Protein intake, preterm infants, they require more protein than full-term infants. Preterm infants, they require 3.5 gram per kilo per day. But full-term infants, they require less, 2 to 2.5 gram per kilo per day. Composition of breast milk. The main carbohydrate in the breast milk is lactose. The protein in the breast milk is alpha-lactalbumin. The fat in the breast milk is ARA and DHA polyunsaturated fats. Absolute contraindications of breastfeeding is HIV. Any mom infected with HIV virus cannot breastfeed, regardless if she's receiving medicine or not. Human T lymphotropic virus infection also is another contraindication. Active tuberculosis only if the mother is not receiving medicine, but after completion of 2 weeks of appropriate therapy for tuberculosis, the mom can breastfeed with no problem. Infants with classic galactosemia, they should receive lactose-free formula and they cannot breastfeed. What about if the mom is infected with hepatitis B virus infection or hepatitis C? Can she breastfeed? The answer is yes. So hepatitis B virus infection, hepatitis C virus infection is not a contraindication of breastfeeding. Also, if the mom has fever or mastitis or breast abscess, she still can breastfeed. What about if the mom is smoking? Also, the mom can breastfeed, but you should encourage her to stop smoking. Also, if the baby has jaundice, also the baby can breastfeed, but actually more frequent. The main carbohydrate in the preterm formula is corn syrup solids, the glucose polymers. Protein, the weight to casein ratio is 60 to 40, which is very close to that of the human milk. The medium chain triglyceride is the predominant fat in the preterm formula. The calcium to phosphorus ratio for maximum absorption of calcium is 2 to 1. It's very important to know this ratio. Calcium has to be double the ratio of the phosphorus for maximum absorption, especially if you are preparing TPN formula for preterm babies when they are in the hospital. The zinc in the preterm formula is high level, and also the zinc is more than 10 folds higher than that of the copper. Marasmus is a classic example of severe malnutrition. It is non-edematous malnutrition. It is severe energy and protein malnutrition or decreased intake. Not only that, it is combined with recurrent infections like vomiting, diarrhea, or chronic diseases. These children, when you look at them, they have severe muscle wasting and hypotonia. They have visible intestinal pattern, emaciations, wrinkled face, shrunken and wizened face like all men. Listless, they are not playing as other kids. They are less active. Their temperature is below normal. Also, their pulse is slow. Another classic example of severe malnutrition is kwashiorkor, edematous malnutrition. It is a severe protein malnutrition with adequate carbohydrate intake. So they are fine with the carbohydrate, but the problem is the protein. So they have loss of muscle tissue, so they are wasted, they are thin. Also, their face is puffy and they look edematous. Why they look edematous? Because of decreased protein, decrease the albumin or albumin formation, so they have hypoalbuminemia and extravascular accumulation of the fluid, and they develop edema. Also because of decrease of beta lipoprotein synthesis in the intestine, and they cannot carry the fat, and the fat it end up accumulated in the liver, and they end up with large belly or hepatomegaly. So when you see their tummy is big, or their belly is big, is because of large liver, not fat. So it is large liver, not fat. So increased susceptibility to infections. Also, they do not have enough protein to make antibodies. Also in combination with vomiting and diarrhea. So these kids always they have infection somehow, and if you combine infection and energy loss with a decreased protein intake, you end up with kwashiorkor or edematous malnutrition. Children with protein malnutrition also they present with anorexia, lethargy, apathy, irritability. Their skin is mosaic appearance, combination of hyper and hypopigmentation due to loss of zinc. They have low serum zinc because of continuous loss in the diarrhea. Also, they may have even ulceration. Their skin condition may resemble acrodermatitis enteropathica as well. Their hair also sparse and thin, streaky red or gray in dark-skinned children. We'll start now to discuss the water-soluble vitamin. The first one is thiamine or vitamin B1. The sources of vitamin B1 is yeast, legumes, meat, milk, and vegetables. Causes of or possible causes of thiamine or vitamin B1 deficiency: preparing a TPN without adding thiamine, chronic alcoholism, infantile peri-peri. This is the presentation in infants with vitamin B1 deficiency. They may present with congestive heart failure, neuritis, hoarseness or aphonia, absence of deep tendon reflex, anorexia. Adults with vitamin B1 deficiency may present with Werner-Korsakoff syndrome or encephalopathy. They may have confusion, ataxia, ophthalmoplegia, nystagmus, intracranial hemorrhage, and psychosis. It is a routine for all alcoholics when they present to the ER in the emergency department. They receive parenteral thiamine or vitamin B1. Riboflavin or vitamin B2 deficiency. Main sources of vitamin B2 or riboflavin is meat, fish, eggs, milk, yeast, and vegetables. Possible causes: prolonged phototherapy in premature babies. Phototherapy causes degradation and destruction of riboflavin and causes riboflavin deficiency. High prevalence in adolescent females and a family with poor income. The clinical presentation of vitamin B2 deficiency or riboflavin deficiency is chelosis or cheilitis, or the angular stomatitis or inflammation of the angles of the mouth or the lips, glossitis, inflammation of the tongue, keratitis, inflammation of the cornea, photophobia, sensitivity to the light, lacrimation, seborrheic dermatitis, and anemia. Niacin deficiency or B3 deficiency. The sources or the common sources of B3 is milk and eggs. The common causes is alcoholism, prolonged INH therapy, malabsorptive diseases, anorexia nervosa. The classic 3Ds is diarrhea, dermatitis, and dementia. Pyridoxine or vitamin B6 deficiency. Common sources of vitamin B6 is yeast, rice, meat, nuts, and cereals. The common causes or the classic causes of B6 deficiency: isoniazid treatment. If anyone receiving treatment for tuberculosis with INH or isoniazid, they should be supplemented with vitamin B6 in order to prevent the complication of B6 deficiency. Another classic example: exclusive breastfeeding more than 6 months if the mother B6 deficient. Another also example very important to remember is persistent or intractable seizure in a child less than 18 months, pyridoxine dependent seizure. This type of seizure may present even during pregnancy at 20 weeks of gestation. Syndromes associated with B6 deficiency, for example, homocystinuria. Pyridoxine B6 deficiency may present with microcytic anemia, refractory seizures in infancy, pyridoxine dependent seizure, sensory neuropathy, dermatitis. It is very important to know, any child present with seizure persistent and with no clear etiology, they should receive a trial of pyridoxine. Very important to remember that. Let's take a clinical case scenario. This is a 1-year-old girl presents for her well checkup. The mother is concerned because she is not developing like her older sister. The mother is a strict vegan for a number of years. On physical examination, she is at 50th percentile for weight, has mild conjunctival pallor, she's pale. CBC shows macrocytic anemia. What is the most likely cause? The key word in this question is a strict vegan and present with anemia, and the anemia is macrocytic anemia. The most likely cause of this anemia is vitamin B12 deficiency. B12 or cobalamin deficiency. B12 is important for synthesis of DNA, methylation of homocysteine to methionine, demethylation of methyl tetrahydrofolate to tetrahydrofolate, which is important for DNA synthesis and cell division. Sources of B12 is almost exclusively animals. The plants do not have B12. Common causes of B12 deficiency: strict vegans, patients taking their diet only from plants, no animal sources. Removal of the ileum also associated with B12 deficiency because ileum is the site of B12 absorption. Any disease affect the ileum may cause B12 deficiency, for example Crohn's. Crohn's loves the ileum. Pernicious anemia with intrinsic factor deficiency also causes B12 deficiency. Common scenarios you may have in your real life, in your clinic, or in the board exam. Breastfed infant who is exclusively breastfed by mother who is B12 deficient. So exclusive breastfeeding to mother B12 deficient or strictly vegan can cause B12 deficiency in infants. Strict vegan adolescents as well. Clinical presentation of B12 deficiency: megaloblastic anemia, hypersegmentation of neutrophil, paresthesia, numbness or tingling of hands and feet, peripheral neuritis, weakness in the limbs, posterior lateral column degeneration. The patient may present with decreased vibration and touch sensation, vitiligo, especially if associated with pernicious anemia, failure to thrive, fatigue, skin hyperpigmentation, vomiting and diarrhea, icterus or jaundice. Association of B12 deficiency: if the mom is not taking adequate amount of B12 during pregnancy or she is strictly vegan, the child may be born with neural tube defects, for example myelomeningocele. The treatment of B12 deficiency: very important to treat the cause, number one, then after that B12 supplementation. Let's take another case scenario. This is a 6-month-old brought to you because of pallor. The child is pale. The baby is eating less, sleeping more. He has been fed only homemade goat milk based formula. On physical examination, mild tachycardia, pallor. CBC shows macrocytic anemia. What is the most likely cause? The key word in this question is goat milk based formula, macrocytic anemia. Know that goat milk is deficient in folic acid, so the most likely cause is folic acid deficiency. Common causes of folic acid deficiency: goat milk intake, especially in the first year of life, Crohn's disease, sickle cell anemia, malignancy, drugs, for example phenytoin and methotrexate, methylene tetrahydrofolate reductase deficiency. Clinical presentation of folic acid deficiency: megaloblastic anemia, similar to that of B12, hypersegmentation of neutrophil, glossitis, inflammation of the tongue, listless, growth retardation or failure to thrive. If you are presented with a child with macrocytic anemia, the next test to do is serum folic acid and serum cobalamin to differentiate if it is folic acid deficiency or cobalamin deficiency. Also, if the mom is not taking enough folic acid even before pregnancy, the child is at risk to develop neural tube defect, for example spina bifida or myelomeningocele. The treatment of the cause, this is number one. Then after that you supplement with folic acid. It is very important to know if it is not cobalamin deficiency or B12 deficiency, because treating with folate a patient or a child with B12 deficiency will not improve the neurological abnormalities and actually will keep worsening. Let's take a clinical case scenario. This is a 7-month-old girl, presents because of irritability, bleeding gums, not moving her legs. Her diet consists only of evaporated boiled milk. She is eating much less in the last few days. On physical examination, she is in 5th percentile for weight and 10th percentile for height. She is fussy, lying in a frog-legged position. Her gums are bleeding and necrotic. What is the most likely cause? The key word in this case is bleeding gums. She's not receiving regular formula or breast milk. She's receiving milk, evaporated boiled milk, which is usually deficient of vitamin C. And also she has pain in her legs and laying down frog-legged position. So this is a classic case presentation of vitamin C deficiency. Vitamin C deficiency. Know that vitamin C is very important for collagen synthesis, connective tissue integrity, and also plays a role in iron absorption. Common sources of vitamin C, fruits and vegetables, human and cow milk. The classic presentation of vitamin C is gingivitis, like bleeding gums, cutaneous hemorrhage and purpura, leg tenderness. And this explains why the girl in the previous case was laying down in frog-legged position, because of subperiosteal hemorrhage. Know this combination between vitamin C and the subperiosteal hemorrhage. Muscle pain, they may bleed inside the muscle or even the joint, and they can cause hemarthrosis, pseudoparalysis, poor wound healing, T-cell dysfunction. Know that vitamin C protects against bacteria, for example, diphtheria, tetanus, and typhoid. Excess intake of vitamin C can cause renal colic because of kidney stones and nephrolithiasis. Can cause also diarrhea and nausea. For kids that have G6PD, they may present with hemolysis because of vitamin C intake. Also can cause dental decalcifications. Fat-soluble vitamins. Very important to remember all these vitamins. Vitamin A, D, E, and K. Or you can pronounce it as ADEX to remember it. The absorption of fat-soluble vitamin require two things: surface area and enzyme. Surface area, so if someone has short bowel syndrome or loss of bowel, they may present with deficiency of any of these vitamins. Enzyme also deficiency, pancreatic enzyme deficiency, or bile salts deficiency, like the classic cases of that, celiac disease and cystic fibrosis, for example. They may present with vitamin A or D or E, K deficiency. Vitamin A deficiency. Vitamin A found in green leafy vegetables, carrots, and sweet potato. The most common cause of the vitamin A deficiency: malnutrition, of course, Crohn's disease, celiac disease, hepatic failure. The first symptom appear nyctalopia, which is a fancy word of night blindness. This is the first symptom usually appear. Photophobia and light sensitivity. The eye become dry and xerophthalmia. If the dryness reaches the cornea, this is really a big problem, and it may cause corneal ulceration. When the cornea become ulcerated, it may turn cloudy and become keratomalacia. Clouding of the cornea is a medical emergency and require high dose of IV vitamin A. Your hope when you treat this case to have partial recovery at this point. Vitamin A deficiency, they present also with betoto spots. Betoto spots is a buildup of keratin located superficially on the conjunctiva. It may look oval or round or triangular or irregular shape as this figure. Also, if someone develop measles and vitamin A deficient, the mortality rate is very high. Vitamin A deficiency affects the skin as well, not only the eye, and they have hyperkeratinization of the skin. Their skin becomes scaly and rough, and what is well known as follicular hyperkeratosis. Also, they have retarded growth. Also, to go back to this point, is very important to know if any patient meet the criteria for measles, they must receive vitamin A. So if any patient present to you with fever 101 or higher, cough, coryza, conjunctivitis, the classic 3 C's, they must be reported to the CDC and given vitamin A supplementation, and the vitamin A dose here is age dependent. Excessive intake of vitamin A also associated with complications. If you have a patient presented to you with headache, diplopia, papilledema, and you decide to do a CT scan, the CT scan comes normal, then you go for LP and the opening pressure is very high, the diagnosis is pseudotumor cerebri. So you have to ask the patient about medication intake. If the patient taking vitamin A, this is your diagnosis. Excessive vitamin A intake can cause pseudotumor cerebri, or the other name, idiopathic intracranial hypertension, also associated with anorexia, large liver and spleen, and hair loss or alopecia. Let's take another case scenario. A 16-month-old girl with bow legs has not developed any teeth yet. She is exclusively breastfed from birth and was not given any vitamin supplementation. On physical examination, she is below 50th percentile for weight and height, no teeth. She has bony protuberances along the anterior chest wall, widened wrist and bowed legs. What is the most likely cause? This is a classic example or a classic case of vitamin D deficiency. The key word in this case to look at is exclusive breastfeeding. Know that any baby born with breastfeeding only must receive vitamin D from birth. Also, growth failure or height and weight below 50th percentile is another key word. Bony changes like bony protuberances or rachitic rosary along the anterior chest, widened wrist and bowed legs. Vitamin D deficiency. The common sources of vitamin D is cod liver oil, liver and meat, egg yolk, oily fish like salmon or sardines. The two main sources of vitamin D is the fortified food with vitamin D and sun exposure to activate vitamin D in the skin. The most common cause worldwide is nutritional of vitamin D deficiency. Clinical presentation, patients may have no symptoms at all. Poor growth or growth failure, tetany because of hypocalcemia, muscle weakness, skeletal deformities, delayed teeth formation. Excess vitamin D or excessive intake of vitamin D can cause hypercalcemia, constipation, nephrocalcinosis because of excessive excretion of calcium, renal and kidney stones, and myositis ossificans. Let's discuss another case scenario. This is a 13-month-old boy was born at 24 weeks premature who has neonatal cholestatic jaundice. Awaiting for a liver transplant, he was noted to be hyporeflexic and have generalized weakness. His alpha tocopherol level is very low. What is the most likely cause? The most likely cause here is vitamin E deficiency. This is a classic case of vitamin E deficiency. The key word here you look for is cholestatic jaundice and deficiency of bile salts to reach the ileum to be able to absorb the vitamin E, and also in the manifestation hyporeflexia. Hyporeflexia also one of the manifestation of vitamin E deficiency and generalized weakness. Vitamin E deficiency or tocopherol, you need to remember the other name of vitamin E, tocopherol. The function of vitamin E is a strong antioxidant and terminate the radical chain in the cells. The common causes of vitamin E deficiency: biliary atresia, very low birth weight premature infants, common in children with cystic fibrosis, and other causes of malabsorption. Clinical presentation of vitamin E deficiency or tocopherol deficiency: hyporeflexia or areflexia, depends on the degree of deficiency, ataxia, loss of proprioception and vibratory sense, dysphagia and dysarthria. Cardiac arrhythmias also may present with nystagmus or ophthalmoplegia, so the patient may not be able to look up or look in different directions. Hemolytic anemia, especially in preterm infants. Another case scenario. This is a 5-day-old boy presents with continuous bleeding from the umbilical stump. He is a full-term born via normal spontaneous vaginal delivery at home with a midwife. What is the most likely cause? The key word in this case is a recent birth, 5 days old, present with bleeding, and also was born at home, means that he did not receive vitamin K. This is a classic presentation of vitamin K deficiency. The function of vitamin K is to maintain prothrombin factor 2 and factor 7, factor 9 and factor 10. The common sources of vitamin K is dark leafy vegetables, soybean, bacterial synthesis in the intestine. Causes of vitamin K deficiency malabsorption, for example, cystic fibrosis, ulcerative colitis, intestine resection or bowel loss, especially the ileum, antibiotics, for example, cephalosporin. Breast milk is deficient in vitamin K. So vitamin K actually also do not cross the placenta, and the baby will depend on the gut flora in order to make vitamin K, which is not ready in the first few days. All vitamin K dependent factors are low in the first 2 to 3 days after birth. That's why it is a routine to give vitamin K after birth 1 milligram intramuscular. Babies born at home are at risk because they do not receive vitamin K. Vitamin K deficiency, the classic presentation is hemorrhagic disease of newborn. Common in home born with no IM, vitamin K was given after birth. Diagnosis usually elevated PT. So if you want to test for vitamin K deficiency, you order PT. So the PT will be elevated. The prophylaxis routine vitamin K prophylaxis is 0.5 to 1 milligram IM or intramuscular at birth. The treatment is vitamin K followed by fresh frozen plasma. Iron deficiency anemia. The peak or the presentation of iron deficiency anemia 6 to 20 months of age, especially exclusively breastfed infants. So it is really recommended for all infants full term to start iron supplementation at 4 months, and if they are preterm to start from birth. Screening is recommended at 1 year and 2 years of age. This is the bright future recommendation. Iron deficiency anemia, they present with decreased work capacity, they do very poor in the school, growth retardation, increased susceptibility to infection, irritability, and stomatitis. Iron deficiency anemia also, they present with glossitis or inflammation of the tongue, cheilitis or angular stomatitis, increased lead absorption, and this makes the anemia worse, craving for ice or pagophagia, pica, which is interest to eat non-food items, lower IQ scores. This is very important for us to prevent iron deficiency anemia, to prevent these major consequences and lower IQs. Zinc deficiency. Causes of zinc deficiency: malabsorption, low nutritional intake, excess loss, like for example chronic diarrhea. Clinical presentation: alopecia, hair loss, diarrhea, dermatitis, frequent infection due to T-cell dysfunction, failure to thrive, loss of taste or hypogeusia, ophthalmologic problems. Acrodermatitis enteropathica. It is autosomal recessive inherited defect in zinc transport. It is very rare. Presents shortly after weaning from breastfeeding. They present with erythematous scaly skin around the mouth and the anus, what is well known acral dermatitis. So erythematous scaly skin around the mouth and the anus, and is well known as acral dermatitis. They present also with alopecia, refractory diarrhea. Copper deficiency may present with microcytic anemia, chronic diarrhea, neutropenia, flaring of long bone metaphysis, which is very similar to vitamin D deficiency, but the difference in vitamin D level will be normal, periosteal elevations and fractures. Menkes kinky hair syndrome. It is X-linked recessive defect in the copper transport ATPs. The clinical presentation: growth retardation, abnormal hair like kinky, colorless, and friable, cerebellar degeneration, optic atrophy, early death if untreated in the first 3 years. Also, they present with hypothermia, hypotonia, seizures, and the serum copper and ceruloplasmin at this point are low. You can prevent the progression of this disease by giving copper early in the neonatal period, subcutaneously on daily basis for life. Selenium deficiency, cardiomyopathy, abnormalities of hair and nails, myositis, and macrocytic anemia. Biotin deficiency, they present with alopecia, dermatitis, hypotonia, hyperesthesia. Iodine deficiency, goiter, large thyroid, and cretinism. Cretinism means mentally deficient or intellectual disability and short at the same time. Carotenemia. This is a simple condition may present to you, so it's very important to know it. It is a benign condition because of excessive intake of yellow vegetable like carrots. The clinical presentation, you will see the yellow skin, especially the nose, and the eye or the sclera is normal. The management is just reassuring the parents it is not jaundice. Phosphate. Phosphate is connected to a syndrome well known as refeeding syndrome. Refeeding syndrome occurs when you start suddenly feeding full calories a severely malnourished patient. They present with organ failure, severe hypophosphatemia, and electrolyte disturbance. So if you have a patient, for example, with anorexia nervosa present to you and you start feeding them full calories suddenly, this will stimulate the insulin and this will increase the synthesis of glycogen, fat, and protein. This will consume phosphate, magnesium, and potassium, which is already depleted from the body. The child is already very thin and malnourished. So the liver start to make more carbohydrates and build more carbohydrates and by phosphorylation, and this will consume a lot of ATPs. When the ATP become depleted in the red cells, they will have red cellular dysfunction and inadequate delivery of oxygen to the body organs and organ failure, and they may end up even with death in severe cases. Failure to thrive. It is really difficult to find a single definition for failure to thrive. Generally, if the weight is less than 3rd or 5th percentile on the weight for length curve, or the weight drops down 2 major percentile lines, or if the weight is less than 80% of the ideal weight for age. Generally, you have to plot the weight, length, and head circumference in a growth curve in order to have a good information. So if the parents are concerned about the weight and you plot the weight and the length and the head circumference in a growth curve and looks normal, you just to provide reassurance. There are many conditions associated with failure to thrive must be considered according to the history, physical examination, and laboratory. For example, gastroesophageal reflux disease can cause failure to thrive. Malrotation with intermittent volvulus, increased intracranial pressure, for example, brain tumor, celiac diseases in children or infants more than 6 months when they start regular diet. Child abuse, if the history suggests, must be considered. Milk protein intolerance or sensitivity, or cow milk protein colitis or allergies. I had a patient before with cow milk protein allergy when the mother restricted the cow milk intake in her diet and she was breastfeeding. The child started to catch in his growth, and the actually was associated with eczema, and the eczema disappeared as well. Congestive heart failure, chronic renal diseases like renal tubular acidosis must be considered. UTIs, this is a very important one, can cause also failure to thrive. Endocrine disorder like hyperthyroidism can cause that. Syndromes, for example, Russell-Silver syndrome, a child with failure to thrive, loss of appetite, asymmetrical limb development. As you see in this growth curve, this child was doing very well until age of 5. Then between age of 5 and 6, the weight start to drop to below 30 percentile. This is failure to thrive, and you see here the weight is more affected significantly than the height. So this is nutritional, this is gastrointestinal problem. This is a classic example of cystic fibrosis or celiac disease. Laboratory evaluation for failure to thrive. CBC, complete blood count, to check for anemia and blood disorder. Complete chemistry panel to check for metabolic acidosis, renal tubular acidosis, renal function, and liver function. Celiac screening. The best and most sensitive test for celiac is anti-tissue transglutaminase IgA antibodies. Some suggest to test IgA level to rule out IgA deficiency, which is a rare condition. Celiac disease must be considered in an infant more than 6 months after introduction of regular diet and failure to thrive. Stool examination for fat and reducing substances. The sweat chloride test for cystic fibrosis. Remember, cystic fibrosis must be considered in any infant with failure to thrive or any child with failure to thrive, even in absence of pulmonary symptoms. TSH and free T4 for thyroid function. Urinalysis to rule out UTIs. Indication for hospitalization in patients with failure to thrive. Generally, they are managed as outpatient, but this is some exceptional condition where the child have severe malnutrition, medically unstable, outpatient management is difficult, evidence of physical abuse or neglect, very disturbed parents, abnormal child-parents interaction, poor parental function. Management of failure to thrive. Failure to thrive management is a multidisciplinary team approach, and this is the best way to manage failure to thrive. Generally, you have to watch the behavioral and interaction problem during feeding between the mom and the child, or the parents and the child. Your goal in the management of failure to thrive to improve nutrient quantity and quality. Also, you optimize the feeding practices and overcome any food aversion. Occupational therapy and speech therapy can help a lot with that. Also, treatment of the cause or underlying condition is very important. Now we'll start a new section, acute abdomen. Close to acute abdominal pain, if the pain starts suddenly, you must consider mid-gut volvulus, especially if it's associated with bilious vomiting and abdominal distension. Intussusception also is a possible cause of acute abdominal pain, especially in children around age of 9 months. If they presented with colicky abdominal pain and lethargy. Also, the intussusception can present later in life if there is a leading point. Ovarian torsion. Any female present with abdominal pain, ovarian torsion must be in your differential. Any boy present also with acute abdominal pain, the testes must be examined because of possibility of testicular torsion as a cause of abdominal pain, and you have only few hours to save it. Trauma. Also is a possible cause of acute abdominal pain, for example visceral rupture or injuries like spleen or liver rupture. Also hemorrhage or like for example duodenal hematoma. Child abuse must be considered in this case. Also, this is very common with bike injuries and when the handle hit the epigastric area. Also bilious vomiting. This is also a clue for a surgical emergency. The bilious vomiting, especially if it's persistent, like for example volvulus and intussusception. Tenderness and guarding, appendicitis and cholecystitis. Cough and respiratory symptom, for example, a patient with right lower lobe pneumonia may present with abdominal pain, even with no cough and respiratory signs, and sometimes found incidentally when they do CT scan for the appendix, and they find the right lower lobe pneumonia incidentally in the CT scan. If the pain related to meals, the possible causes gastritis and peptic ulcer disease. Medications, for example, NSAID. So ask in the history about chronic condition requiring using of pain medicine, for example, migraine. So NSAID-induced dyspepsia will be the possible cause of abdominal pain at this point. Female adolescents, when they present with pain, you should consider pregnancy or PID, pelvic inflammatory disease, Fitz-Hugh-Curtis syndrome, perihepatitis, and ectopic pregnancy. So any adolescent female present with acute abdominal pain, you should do a pregnancy test. Non-specific causes of acute abdomen. Constipation. Constipation is a very important cause of abdominal pain in children. Ask about hard stool, difficulty with bowel movement, previous history of constipation. Gastroenteritis. Ask about vomiting and diarrhea. Mesenteric adenitis can be even mistaken with appendicitis and sometimes difficult to differentiate without imaging studies. UTIs. Ask about previous history of UTI. Ask about dysuria, urgency or frequency. Ask also about previous history of constipation, which is a common cause of UTI. Functional abdominal pain is a diagnosis of exclusion. Bleeding from the lower GI, like for example current jelly stool, is a late presentation of intussusception. Acute appendicitis. Diagnosis of acute appendicitis in young children is very challenging, and missing this diagnosis is very common, and the rate of perforation is high, and the younger they are, the higher the perforation. Acute appendicitis may present at any age, even neonates, so should be considered, and you should have high index of suspicion for any child present with acute abdomen or lethargy or poor feeding, for example. Classic presentation of acute appendicitis, nausea and vomiting, but nausea may not present, and absence of nausea or anorexia does not rule out appendicitis. Fever is classic or common with appendicitis, but absence of fever does not rule out appendicitis. Abdominal pain. The pain usually classically with any movement, especially walking, is very important sign for appendicitis. Abdominal pain is usually progressive, different than gastroenteritis. Usually the pain keep getting better with time. Guarding. Gentle finger percussion is a better test for peritoneal irritation, so avoid deep palpation, is very painful. Localized abdominal tenderness is the single most reliable finding in the diagnosis of appendicitis. So repeated physical exam is very important and a close follow-up for the diagnosis of appendicitis. Differential diagnosis of appendicitis, mesenteric adenitis. This is very important to consider as a cause of abdominal pain. Can cause acute abdominal pain, very similar to appendicitis, but the symptom keep getting better with time. The child is less toxic appearing. Enlarged mesenteric lymph node in ultrasound. Normal appendix on ultrasound. History of ingestion of raw pork may be obtained in the areas with endemic Yersinia. Right lower lobe pneumonia is a very important cause to consider in cases of acute abdomen. So any child present with acute abdomen and you have the appendix is normal, do chest x-ray. Cough may be present or may not be present. So absence of cough also is a misleading cause of missing right lower lobe pneumonia. Abnormal breath sound may be present. A chest x-ray will confirm the diagnosis. Physical examination. Ravsing sign. Ravsing sign is a right lower quadrant pain when you palpate the left lower quadrant. So you palpate the left lower quadrant. This will cause tenderness in the right lower quadrant. Obturator sign, when you do internal and external rotation of the flexed right hip, this will cause right lower quadrant pain. Psoas sign, when you do extension of the right hip, this will cause right lower quadrant pain. Or also you can do it another way by flexion of the right hip against the resistance. This will give you a right lower quadrant pain, or well known as psoas sign. Remember, this is very difficult to perform in very young children. Other signs which is not common, but sometime I use it and is very helpful. For example, Dunphy sign, which is sharp pain in the right lower quadrant elicited by coughing. So when they cough, they increase the intra-abdominal pressure and cause abdominal pain in the right lower quadrant. Merkel sign, also when you ask the child to stand up in the tippy toe and drop suddenly, this can cause pain in the right lower quadrant as well. Laboratory evaluation of acute appendicitis. Remember, acute appendicitis is a clinical diagnosis and do not require lab. But this will be very helpful in the cases of atypical presentation or very young children. CBC can be normal in the first 24 hours. So normal CBC do not rule out appendicitis. White blood cell can be elevated up to or more than 20,000 in perforated appendix. Urinalysis also may be positive for white blood cells. So presence of white blood cells in urine do not rule out appendicitis, but the urine will be free of bacteria. Serum amyloid A protein also is elevated in acute appendicitis. Ultrasound. Ultrasound is an excellent tool for the diagnosis of acute appendicitis. It is safe, very sensitive, and widely available. Diagnostic criteria of ultrasound: wall thickness more than 6 mm, luminal distension, lack of compressibility. Normal appendix must be visualized. If you cannot see the appendix, you cannot rule out appendicitis on ultrasound. CT scan. CT scan is the gold standard test for appendicitis and can be used in cases of physical finding is uncertain, experienced ultrasonographer is not available, equivocal presentation after cellular examinations, and under observation 12 to 24 hours. So really you try to avoid CT scan if you can. Clinical case. This is a 4-year-old boy presents with abdominal pain, nausea, guarding while walking, and tenderness in the right lower quadrant. The ultrasonographic finding here is a distension of the appendix, as you see here. The distension or the appendix diameter or the thickness is more than 6 mm. Here is 12 mm. And also lack of compressibility. This is a classic case of acute appendicitis. Here in the x-ray you see the fecalith or the calcification in the appendix. Management of acute appendicitis. If you present with a classic case in the board exam, classic case of acute appendicitis, the next step is surgery, not investigation or imaging study or laboratory. So if they give you a classic presentation of appendicitis, the next step is surgery. Morphine and analgesia does not change the diagnostic accuracy, so do not leave your child in pain because you don't want to miss the diagnosis of appendicitis. Antibiotics, cefuroxetine, 1 perioperative dose is important. Post-operative in cases of perforation 3 to 5 days. where in cases of perforation you can use ampicillin, gentamicin, and clindamycin or metronidazole, ceftriaxone, and metro or imipenem. Volvulus. It is important to know about volvulus is a surgical emergency and must be considered in any child present with persistent bilious vomiting. It is incomplete rotation of embryonic bowel with cutting of blood supply to the small intestine, which can cause necrosis and gangrene of a small bowel. Delaying the surgical intervention is not acceptable and can cause short bowel syndrome or even death. Volvulus typically presents early in life before 1 year of age, but can present at any age. Also know that absence of bilious vomiting does not rule out volvulus, especially if the obstruction above the duodenum. Clinical presentation of volvulus pain. Pain is a classic presentation of volvulus, especially in older kids. The pain is usually dull. Aching abdominal pain may be the first symptom. Dramatic pain also may be present. Pain is very difficult to detect in infants, but the infants may present with lethargy, poor feeding, and persistent cry. The vomiting is bilious, so bilious emesis signals surgical emergency, especially if it's persistent. Abdominal distension also is usually associated with volvulus. Rectal bleeding is a late sign because of vascular compromise to the mucosa or intestinal mucosa. This is upper GI series of a child present with mid-gut volvulus, and you can see here the corkscrew sign, which is helical and spiral sign indicating small bowel obstruction. Plain X-ray or KOB will show dilated stomach and the proximal duodenum. The upper GI series with contrast, it is the primary test for volvulus study, and if the contrast ends abruptly or tapers in the corkscrew appearance, this is a classic finding in upper GI with contrast. Ultrasonography is being used also for detection and diagnosis of volvulus and malrotation. Once you are presented with a case of suspected volvulus, you must immediately consult pediatric surgeon before even doing any investigation. Intussusception is the most frequent cause of intestinal obstruction. Needs high index of suspicion in order to detect it early and prevent the complication of intussusception. Intestine is pulled antegrade into the adjacent part of the intestine, trapping the more proximal bowel in the distal segment, causing obstruction, and may cause also necrosis and loss of bowel if it is not treated on time. The most common age is infants, but may occur also in older children because of leading points. Common sites is the ileum and colon, and the ileum usually pulled into the colon. The leading points, for example, polyps, a tumor, which may explain the late presentation. Diverticulum also, or mecal diverticulum, may act as a leading point and cause intussusception. Causes of intussusception. The cause in infants is typically unknown. Also, enlarged mesenteric lymph node caused by viral infection like gastroenteritis can be a cause of intussusception. Mecal diverticulum. Tumors also may explain the late presentation in older children like lymphoma or polyp, hematoma, ganglioneuroma, duplicate cyst, foreign body, hemangioma, sutures, or stable along anastomosis. Clinical presentation of intussusception. Abdominal pain. The abdominal pain may be periumbilical, may be in the right lower quadrant region. The pain is often intermittent, comes and goes, but the continuous pain is unique about appendicitis. The pain is continuous, doesn't come and go. The lethargy is out of proportion of the abdominal pain. Remember that lethargy may be the only presenting symptom in infants. Vomiting, but absence of vomiting does not rule out intussusception. Also, the vomiting can be bilious and non-bilious. Pallor, the patient looks pale and weak. They may lay quiet in between the peristaltic waves. Prolonged obstruction can cause abdominal distension and rectal bleeding. Red currant jelly is a classic late finding or late presentation in intussusception, and it suggests vascular compromise. So do not wait for a patient to present you with red currant jelly or bloody stool in order to diagnose intussusception. Even in the pediatric board examination, if the case presents to you and they said the stool is non-bloody, it can be intussusception. Sausage-shaped mass may be present or may be palpable in the right upper quadrant. Diagnosis of intussusception. The diagnosis of intussusception is a clinical diagnosis, but when it comes to the imaging study air contrast enema, it's diagnostic and therapeutic, and this is the first choice. Ultrasound is an excellent choice as well if the diagnosis is possible intussusception. It may show tubular mass in the longitudinal view, donut or target appearance. Ultrasonography is very accurate in detecting intussusception. The sensitivity is very high. The specificity, as you see, is very high. It is the test of a choice for assessment of possible intussusception, and soon it may be the initial test of a choice. But when it comes to the board examination, if you are presented with a classic case of intussusception and they give you the diagnosis or diagnostic imaging study of a choice, and you are presented with air contrast enema and ultrasound, your choice will be air contrast enema. This is a 7-month-old girl presents with severe intermittent colicky, abdominal pain and lethargy. She looks better in between bouts of cry. Physical examination shows right upper quadrant, sausage-shaped mass and emptiness in the right lower quadrant. The radiological finding here, you will see the donut sign, which is telescoping of the small intestine. And after doing the barium enema, you will see the trace of barium in the terminal ileum after the reduction. This is a classic case of intestinal intussusception. Management of intussusception is air contrast enema, and you do also air contrast enema again if it's recurrent, unless there is a possibility of lead point. The surgery will be an option at this point. Prognosis. You have to tell the parents there is a recurrence rate 10% and they must bring the child back if the child presents with similar symptoms. Most recur within 72 hours. More than one recurrence suggests a lead point. Ileus. Ileus is impaired intestinal motility and decreased peristalsis in absence of mechanical obstruction. The clinical presentation of ileus is abdominal pain, abdominal distension, vomiting, hypoactive bowel sounds. Causes of ileus: abdominal surgery, infections and sepsis, electrolyte disturbance, for example hypokalemia, medication, narcotics like giving excessive morphine before surgery, anesthetics, and some chemotherapeutic agents. Management of ileus is mainly supportive. Discontinue feeding and give IV fluid. Decompression of the abdomen by inserting NG tube if vomiting and distension. If there is no vomiting and no distension, there is no need for NG tube. Treatment of the underlying cause. Surgical consultation of bowel obstruction or it's a surgical complication. Acute pancreatitis. Causes of acute pancreatitis: abdominal trauma is the most common cause in pediatrics. For example, blunt trauma like car accidents or child abuse or bicycle accidents where the handlebar hit the abdomen. Anomalies of pancreatobiliary system, multi-system disease, drugs and toxins, for example azathioprine, tetracycline, L-asparagine, valproic acid, steroids, and immunosuppressive agents. Viral infection can cause pancreatitis. Hereditary disorders, metabolic disorders like, for example, high level of triglyceride, hypercalcemia, cystic fibrosis. 25% of the etiology is unknown. Clinical presentation of acute pancreatitis: abdominal pain. Pain referred to the back, but this varies in the children. So if the pain does not refer to the back, this does not rule out pancreatitis. So absence of that in children, you still think about pancreatitis. Vomiting, abdominal tenderness, abdominal distension. Pancreatic pseudocyst will, in addition to the pain, they will have a mass, epigastric mass. Diagnosis of acute pancreatitis: amylase and lipase, they are elevated. The level at least 3 times more than normal in acute pancreatitis. Remember that normal value of amylase or lipase do not rule out or exclude the diagnosis of pancreatitis. Lipase, however, is more specific than amylase. Coagulopathy, leukocytosis, hyperglycemia, glucoseuria, hypocalcemia, hyperbilirubinemia. Ultrasonography in acute pancreatitis is the most useful initial test. Another method of diagnosing pancreatitis: endoscopic ultrasonography. Endoscopic ultrasonography, more detailed image you will obtain. Transducer can be introduced directly adjacent to the pancreas. Abdominal CT scan if tumor is suspected, but the initial study in children is abdominal ultrasonography. MRCP and ERCP for detailed diagnosis, but ERCP is more invasive. Treatment of acute pancreatitis is supportive. You place the patient in PO. The patient may eat if the food does not cause pain. Narcotics should be used for severe pain. Intravenous fluid for hydration. Intravenous acid suppression to prevent ulcers. Nasogastric tube to decompress the stomach. PQ or ICU transfer in severe cases. Acute pancreatic pseudocyst. If less than 5 cm in diameter, observation for 4 to 6 weeks, mostly resolve spontaneously. If more than 5 cm in diameter, may require surgical intervention. Recurrent pancreatitis. Causes of recurrent pancreatitis: hyperlipidemia, especially triglyceride, hypercalcemia, hereditary pancreatitis. This is the most common cause in US of relapsing pancreatitis. Clinical presentation: chronic abdominal pain, which is difficult to treat. Associated risk of recurrent pancreatitis is pancreatic insufficiency, adenocarcinoma, and pancreatic pseudocyst. Let's discuss a clinical case scenario. This is a 5-year-old boy who has recurrent crampy abdominal pain for 1 year. Now the pain is more severe, associated with non-bilious vomiting after each meal for the past 24 hours. He has a strong family history of early death from cardiac disease below 50 years of age. Physical examination: the abdomen is tender in all quadrants and more in the epigastric area. The labs showed elevated lipase and amylase. The abdominal ultrasound is positive for pancreatitis. What is the most likely cause? Viral pancreatitis, hyperlipidemia, gallstones, hypercalcemia, or hereditary pancreatitis. The key word in this case: recurrent crampy abdominal pain, early death from cardiac diseases below 50 years of age, which indicate there is hypercholesterolemia in the family, elevated lipase and amylase, and of course the pancreatitis. The most likely cause in this case is hyperlipidemia because of the family history of hypercholesterolemia. Acute cholecystitis. Gallstones is the most common cause of acute cholecystitis. Hemolytic disorder like sickle cell disease or G6PD, TPN, medication like ceftriaxone, ileal resection, cystic fibrosis, acalculous or without stone, dehydration, and biliary stasis. Clinical presentation of acute cholecystitis is right upper quadrant pain. The pain is occasionally radiates to the back. Murphy sign is a classic sign of acute cholecystitis. Palpation of the right upper quadrant at the costal margin while the patient breathing in. This can elicit or cause pain. Murphy sign is strongly suggestive of gallbladder disease. Also, they may present with fever, vomiting. Jaundice often present, especially in children. Two common types of gallstones: the cholesterol stone and the pigment gallstones. Cholesterol stone is radiolucent. It has cholesterol, calcium salts, and glycoprotein. The pigment gallstones is black, often already opaque, usually associated with hemolytic diseases. Ultrasound may show the stones. Also, ultrasound may show the thickened gallbladder wall and gallbladder dilation. Hepatobiliary scintigraphy is indicated if the stone cannot be visualized. Liver enzyme can be elevated in acute cholecystitis. GGT can be elevated, alkaline phosphatase as well. Direct bilirubin, white blood cells, amylase, or also they can be elevated. Treatment of acute cholecystitis: bowel rest, intravenous pain control, and intravenous fluid. Antibiotics if fever and if the child looks sick or unstable. The timing of curative cholecystectomy is determined usually best with the surgeon. Complication of cholecystitis is perforation of the gallbladder with peritonitis or abscess formation. Acalculous cholecystitis typically occurs during a significant systemic illness such as sepsis, illness requiring a stay in the intensive care unit. Choledocholitis and cholangitis. Choledocholitis is a stone in the bile duct and usually present with biliary colic and abdominal pain. Cholangitis is infection of the bile duct. The mechanism is complete obstruction of the bile duct to cause dilation, then jaundice, and then bacterial proliferation and cholangitis. Clinical presentation of cholangitis: a Charcot triad, fever, right upper quadrant pain, jaundice. Tenderness is consistent with impacted stones. Laboratory evaluation of cholangitis: elevation of GGT, alkaline phosphatase, conjugated bilirubin, AST, and ALT. Amylase and lipase, if they are elevated, there is a possibility of associated pancreatitis. Stones may be seen in ultrasonography in cases of cholangitis, but sometimes it's hard to see. Also, you may see dilated duct as well. The management of acute cholangitis, it is considered a surgical emergency. Antibiotics should be started as soon as possible if the fever is present. You place the patient in PO or nothing by mouth, intravenous fluid, and pain medicine. Inguinal hernia. All pediatric inguinal hernias must be treated. Clinical presentation: visible swelling or bulge, commonly intermittent. You have two types, one in boy and one in girl. In the boys is inguinoscrotal, and in girls inguinolabial. Management of inguinal hernias: hydrocele without hernia neonates can be delayed to 12 months. The inguinal hernia must be surgically repaired as soon as possible because of risk of incarceration. Umbilical hernias. Most umbilical hernias do not cause any symptoms, do not require surgical repair until approximately 5 years of age. Almost all umbilical hernias, they are self-limited and spontaneously resolve, and they require only simple observation and reassurance. Next video will be the part 2 of the GI chapter, starting from page 264. This video is only for educational purpose. Please consult the doctor of your child for the correct diagnosis and the proper treatment. Thank you.